All right, hi. Like I said, my name's Emily. My name's Emily Cohen, and I'm the Administrative Director here at Clearview Treatment Programs. I'd like to welcome you to our live stream community event. We're pleased to offer these events to members of the community every couple of months, and we hope you'll come back for some more. Before I introduce our main speaker, I wanted to tell you a little bit about Clearview and what we offer. Clearview, we've been around since 2000, and we offer a full continuum of care for substance abuse, dual diagnosis, and mental health issues. We have an IOP program. We have an outpatient program in Westwood. We offer detox, residential treatment for both dual diagnosis, substance abuse, and mental health issues. So our main focus, or one of our main focuses, is evidence-based practices such as dialectical behavior therapy, DBT, cognitive behavioral therapy, acceptance and commitment therapy, seeking safety, motivational interviewing, prolonged exposure therapy, and we utilize the matrix model for relapse prevention and education for addiction. We do lots of training for our staff and for the community, and we also have a collaboration with Yale University to do outcome studies. All of our staff members are intensively DBT trained by behavioral tech and other training institutes. We do lots of clinical consultation with thought leaders in the various evidence-based fields. We do program development and weekly consultation with Dr. Charlie Swenson, and we're working on DBT certification for our program. Where you are today is our Clearview Women's Center for BPD and Emotional Dysregulation. It's a residential treatment center for women with borderline personality disorder and who also suffer with issues of emotion dysregulation. We also treat mood disorders, some anxiety disorders, PTSD, and other personality disorders. It's an intensive, comprehensive DBT program. We follow the model as it was written. We do the DBT skills training groups, individual DBT therapy. We do coaching within the milieu and phone coaching when the clients are off-site. And all of our therapists, in addition to being intensively DBT trained, have a consultation team meeting. Other therapies are the ones that I mentioned at the beginning, CBT, ACT, prolonged exposure, seeking safety. And then because we offer a full continuum of care, you can step down into a partial hospitalization program, or PHP, which is day treatment, intensive outpatient, which is a shorter outpatient program, and then also a longer term outpatient where you attend group and individual therapy. The intensive outpatient and outpatient are held at our outpatient center in Westwood. That's where Clearview started. We started as a single outpatient program, and as we saw the need grow for different types of treatment, and we expanded. So as I mentioned, our outpatient center is in Westwood, and we also offer a pretty full continuum of care there. We have our partial hospitalization, or PHP, or day treatment, and that's 5 days a week. It's 6 hours a day. It's basically a full day of treatment. It's about 9 to 5 with individual therapy twice a week, about 4 to 5 group therapy sessions a day, and psychiatry. From there, in addition to PHP, there's an intensive outpatient, or IOP as we call it, which is 3 hours a day, 3 to 5 days a week. And it includes 2 group therapy sessions a day and 1 individual therapy session a week. We also have the individualized outpatient program, which consists of group and individual therapy, anything from 2 to 5 groups per week. We also have a standalone DBT programs, which is again the model as it was written. So it's individual DBT therapy, DBT skills groups, and phone coaching. We offer a variety of family programs as well at the outpatient center in Westwood. We offer a weekly family support group for family members. They don't have to have clients or loved ones in Clearview. It's open to members of the community who are struggling with issues of substance abuse or dual diagnosis. That's facilitated by one of our therapists. And then for clients that are in the program, at all of our programs, we have a different family education and support groups. At our dual diagnosis program, we have a 2-day family workshop where the families and the clients participate together. At our Women's Center, we have a 6-week workshop where we teach the family members how to communicate with the clients so that they can learn the language that the clients are learning within treatment. And at our outpatient center, we have a similar program. Also, all of the therapists will do individual family therapy as needed. As I said at the beginning, we offer lots of community workshops, and you know, if you're on our mailing list, you'll get word about that. We do lots of education series. We have different, we bring in known speakers in different fields for the professional community. We sponsor several national conferences. We go to different hospitals and institutions in the area to teach them about the types of issues that we treat and the types of treatment that we do. And then several of our therapists and clinicians will go and speak at different places. We accept many insurances. We're in network with Anthem and any members of the Blue Card network. We work with lots of out-of-network providers. And then we're working on getting more in-network contracts so that we're able to reach more people. When a client calls in, we'll verify benefits. We'll try and give you a sense of what we think, you know, if there's an additional cost for treatment, and we'll try and work with the insurance company, and we'll do, of course, authorizations and utilization reviews so that the clients can get the best out of their benefits. The program that I haven't mentioned is Stephen's program. Stephen Rodoy is our clinical director of our dual diagnosis program. It's the Center for Psychiatric Disorders and Addictions. It's dual diagnosis, so we treat people with substance use disorders as well as co-occurring personality disorders, mood disorders, anxiety disorders, including PTSD. We can work with some eating disorders if it's not the primary issue, but it was our first residential program. It's in a home style environment. It's small and intimate. We offer the comprehensive DBT model, but we also offer the other evidence-based treatments that I mentioned. We do group and individual therapy with all of our clients. And our goal is to, you know, the clients will start out in residential treatment, and our goal is to integrate them back out into life. So with that said, Stephen can tell you a little bit more about us, and thank you for letting me tell you about Clearview.
All right. Hi, everybody out there. Hi. I don't know where to look. So I'm used to doing more like talks and lectures with groups of lots of people. So the few of you guys that I have here, feel free to ask questions as we go, because it's easier to have more of a conversational thing, even though I know most of the people that are online can't do that. But people that are online hopefully can send questions in, and then I can answer some of them at the end. This is one of those topics that sort of requires a little bit of thought and discussion because it's unique to each individual family. So I'll do my best to kind of talk about the generalities, but if there's something specific that you'd like to find out about and ways in which I can help, that would be great. The goal of this talk is just to talk about the warning signs of addiction and how to get a loved one into treatment. It's pretty straightforward, but it's a pretty complicated thing to address. Warning signs of addiction, I will say, most people don't need to know because you usually know when your loved one is suffering from addiction, right? It's very infrequent that family members don't know whether someone's suffering from addiction or not, but there are times when the person's not telling you anything. The how to get a loved one into treatment is the more complicated and nuanced. So hopefully we'll get to both of those things. Oh, and I'll just mention really quickly, get through these. This is what Emily all talked about. The dual diagnosis program, which I'm the clinical director of, like Emily said, we treat co-occurring disorders. So everybody in the program has a substance abuse diagnosis, but they also, almost all, not every single person, but most people in the program have a co-occurring mental health disorder. Most often it's co-occurring borderline personality disorder, but we often treat anxiety disorders, depression, all kinds of other things. So we really are trying to look at both the mental health and substance abuse at the same time, which is a little bit different than the sort of more traditional model of splitting those up and kind of in separate places. So that's just a little bit about the dual diagnosis program. Get to my slide. Okay, there we go. So there's a national survey on drug use and health that's conducted every year. The most recent year that we have statistics for is 2017. So this is sort of like a large scale survey that's done. It's government funded, and there's a lot of time and research that's put into finding out what is going on with people with substance use disorders and what kind of numbers we're looking at. So the statistics I'll give you guys are the ones from 2017, which is the most recent year that we have the statistics. So in 2017, it was estimated that 19.7 million American adults battled a substance use disorder. It's somewhere close to 10%. It's somewhere between 5 and 10% of adult Americans. And of those, 74% of those people suffering from a substance use disorder were struggling with alcohol use disorder specifically. So alcohol use is the most common addiction that people are struggling with, although the others are obviously can be even more problematic or more life-threatening, but more people than not are struggling with alcohol abuse than anything else. Also in 2017, 1 out of every 8 adults suffering from a substance use disorder struggled with both alcohol and another substance, so an illegal drug or a pharmaceutical. In 2017, 8.5 million American adults suffered from both a mental health disorder and a substance use disorder. So that's almost half of people struggling with a substance use disorder also have a co-occurring mental health disorder. And that makes sense, and that's exactly why we treat both at the same time, and that's sort of how our model is designed to treat people that are struggling with both. It's estimated that drug abuse and addiction cost American society more than $740 billion annually in lost workplace productivity, healthcare expenses, and crime-related costs. That's pretty staggering. I mean, it's an expensive problem, and it's a problem that I think only recently people are starting to take more seriously because of the opioid epidemic. But up until now, it's really been relegated to the outskirts of society, and people really have not wanted to talk about it, and families have really tried to ignore the fact that it's happening, and it's becoming more and more prevalent in groups that normally wouldn't struggle with this kind of thing, but it's becoming a bigger and bigger issue and is costing more and more money. So it's something that needs to be addressed, obviously, quickly. Oftentimes clients come into our program who are suffering just from alcohol addiction or marijuana addiction, for example, and don't feel like their substance of choice is that big of a problem because it's legal, for example, and it's easily found and a lot of people use it recreationally. I think some of these statistics are just interesting from the perspective of people that are addicted to alcohol are actually 2 times more likely to be addicted to heroin. And those addicted to marijuana are 3 times more likely. Those that are addicted to cocaine are 15 times more likely, and people addicted to prescription drugs are 40 times more likely to be addicted to heroin. So most people aren't just sticking with one thing for extended periods of time. Most people tend towards a specific drug of choice, but it usually kind of opens the door for a lot of other kinds of problematic behaviors. Going back to the opioid epidemic, it's been found recently that women may more rapidly develop a prescription painkiller dependence than men, and women are more likely to have chronic pain, be prescribed pain relievers, and receive higher doses. Approximately 4.1 million American adults over the age of 12 battled a marijuana use disorder in 2017, meaning, and when we'll get to the definitions of where it goes from recreational use into a diagnosable disorder, but meaning that their marijuana use got in the way of their life to the point that it was causing some kind of functional impairment. And then 6% of full-time college students in the US were daily marijuana smokers in 2014. This is more than triple the number of daily smokers in this population 20 years prior. So I always think of the interesting, the difference between sort of how we think of college students today and college students in the late 21st century or 20th century, and the role that marijuana plays, and also the level to which marijuana can be abused now in the various forms that it comes in. Like pretty frequently we get clients whose primary drug of choice is marijuana, but they're using it in wax or resin form, and it's causing really serious reactions and having really severe consequences. we'll get into this a little bit more as we go, but over half of all American adults have a family history of problem drinking or alcohol addiction. So oftentimes we talk about, is alcoholism a hereditary disease? Does addiction run in families? And I think the answer is yes. And at the same time, it pretty much runs in all families. Like I think if you think of any family, there's almost always at least one or two people that you can point out that probably had a problem with drinking or some kind of substance use. So really it's kind of a genetic variant that we all carry with us. And it does tend to run more highly in certain ethnic groups, in certain parts of the country or certain parts of the world. But I really do think in my experience and some of the research kind of shows that it runs across families. Addiction is something that's sort of built into us as an evolutionary mechanism. More than 10% of US children live with a parent with alcohol problems. An estimated 88,000 people die from alcohol-related causes annually. Alcohol is the third leading cause of preventable death in the United States. And this, I thought this was pretty staggering. 40% of all hospital beds in the US are used to treat conditions related to alcohol consumption. So alcohol, as much as it's legal and it's readily available and it's used recreationally often, is actually one of the more dangerous substances that people can use. And it's not well known that although other substances can be really, really painful to detoxify from, alcohol is actually one of the few substances that can kill you in withdrawal because of the nature of the way that it works on the body. So alcohol, as much as it's legal, can be really, really dangerous. Lastly, these are some statistics about treatment. So in 2017, an estimated 20.7 million people needed treatment for a substance use disorder, and only about 4 million people actually received treatment, which is about 19% of those who actually needed it. So I often tell clients in the program that as much as they may resent being in treatment or may have been pushed in one way or another to be in treatment, it's actually a really big gift, because being in treatment is something that not everybody has the opportunity to do. In 2017, of the more than 18 million people who needed but did not receive treatment for substance use, only 1 million, or 5.7% of those people felt they needed treatment. So we'll get to it a little bit down the line when we're talking about how to get a loved one into treatment. But people aren't often excited about going into treatment. That's not necessarily an expectation of getting into treatment, and it's not necessarily required for treatment to be successful. Addiction, by definition, involves some level of denial and rationalization. And so it's very infrequent that someone says, I want to do this 100%, I'm ready 100%. It does happen, but more often than not, there's a significant amount of ambivalence for people. The relapse rate for substance use disorders is estimated to be between 40 and 60%. It's an interesting number because on one hand, it's scary, I think, for loved ones to see that, especially loved ones that are putting so much stock in their loved one being in treatment and getting better and staying better. But the interesting part about that is that that rate is similar to other chronic conditions, chronic diseases like hypertension and asthma. So it's not that 40 to 60% will relapse and never get back on track, but it's just that relapse is an expectable part of the recovery process. The last part is that addiction is considered a highly treatable disease, just like hypertension and asthma, and recovery is possible. So about 10% of adult Americans currently who are at least 18 years old say that they're in recovery from an alcohol or drug abuse issue. So I like to think of that statistic in a couple of ways, but the main thing that I take away from that is that basically 1 in 10 people that you're coming across has struggled with addiction and is in recovery. So that means that the isolation that people often feel as they're entering recovery and feel like they have to change their friend group and they have to change everything about their lives and everything about their life is turned upside down is actually more of a common experience than they realize, and that many people around them have had similar types of experiences. So when does substance use go from just recreational use to abuse or addiction? In the DSM-4, which was the previous DSM, for those that don't know, the DSM is the manual that clinicians use to make diagnoses. So any mental disorder, any substance abuse issue, anything within that realm is in a big thick book that's updated every several years. And it's sort of like the Bible for mental health where we sort of communicate with one another about what might be going on with the person. So in the previous version, there was a strict differentiation between substance abuse and substance dependence. We don't make that differentiation anymore. We just say substance use disorder, and we categorize it as either mild, moderate, or severe. But what's important to know about that is that the use of a substance in and of itself is not problematic according to the manual. So many people use all kinds of substances, alcohol, marijuana, for example, recreationally, and some people even use harder illegal drugs recreationally as well. Where it moves to a substance abuse is when it starts to have what we call when it leads to functional impairment in the person's life. So their substance use is somehow interfering with them doing the day-to-day things that they need to do in order to have a full, fulfilling life. Where we get to dependence is where it starts to have take a physical toll on the person's body. So there's either withdrawal symptoms or there's tolerance for the substance, where they need more and more of the substance in order to get the same effect. So it's sort of like on a continuum where some people may use it recreationally. It doesn't really impact their life. They may use it once every couple weeks, couple months. They're able to work. It doesn't impact their relationships. I don't know those people, but they do exist out there. And then abuse is sort of the person who's starting to have problems, but isn't necessarily physically dependent on the substance. And then dependence is obviously that person who's needing the substance in order to survive. So the DSM-4 was the previous version. The DSM-5 is what we're currently on. And these are the criteria that we look for in diagnosing a substance use disorder. So the first criterion is substances are often taken in larger amounts or over a longer period of time than intended. I think intended is the most important part of that. So people who are abusing substances often don't intend to find themselves where they do. I see it every day when people come to the program. They have every intention of staying sober or making it to work or showing up, getting home on time, and then things happen. So that's one of the things that we look for in figuring out whether a person has a certain level of control over their substance use. Persistent attempts or one or more unsuccessful efforts made to cut down or control substance use. So the person is trying to cut down, but even though they're trying, they're not being able to do that. A great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. Craving or strong desire or urge to use the substance is present. Recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. So that's a big one. Oftentimes, this is one that people who are in the midst of addiction are not acknowledging because there are so many other reasons why these things could be happening. So I haven't been able to work, not because I'm, stuck at home using a substance. It's because I'm unemployable because I never finished college, or it's because this other thing happened, or I got fired, not because of my substance use, but because my boss was mean or whatever. So oftentimes people will rationalize these things, but this is an important thing to look at when you're thinking like, is this a problem or not? People who meet criteria for substance use disorders also have they continue to use the substance despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. Important social, occupational, or recreational activities given up or reduced because of substance use. And then recurrent substance use in situations which are physically hazardous. This is where I think of DUI as being an interesting marker of substance abuse or dependence. Many people get DUIs who don't have a problem with alcohol, but oftentimes people that get DUIs tends to be a signal that something is not working because you're putting yourself in a pretty physically hazardous situation, driving yourself and others by driving a car intoxicated. So oftentimes we'll see clients who come into treatment because they've had a recent DUI and it sort of made them realize that something wasn't working. Substance use is continued despite knowledge of having a persistent or recurrent physical or physiological problem that is likely to have been caused or exacerbated by the substance. So this is where we see people having really negative health benefits, health effects of substance use, and they continue to use even though that's happening. So people have liver failure or neuropathy or all kinds of things, problems with their skin, with their teeth, their throat, and they continue to use despite that. And then 10 and 11 are the ones that we're looking at as far as the physical dependence is concerned. So tolerance, which is defined by either needing markedly increased amounts of the substance in order to achieve intoxication or desired effect, or diminished effect with continued use of the same amount. And then withdrawal, which is manifested by either the characteristic withdrawal symptom of the substance, or using the same or a closely related substance to relieve or avoid withdrawal symptoms. So those are the sort of physical dependence symptoms that we're looking for. Alcohol withdrawal, like I said earlier, is one of the most dangerous withdrawal syndromes that we see. And that's because of the risk of seizure. So alcohol and benzodiazepines like Xanax and Klonopin and things like that are the substances that actually are most likely to trigger a seizure because they actually serve as an anti-seizure. They have an anti-seizure effect, and so the withdrawal from them can actually trigger a seizure in sort of an opposite effect. So people that are physically dependent on alcohol often need some kind of medically supervised detox process in order to make sure that that doesn't happen. But any substance that you think of, kind of as a rule of thumb, the way I think of it is whatever the substance does when you're intoxicated by it, it's going to do the exact opposite when you're withdrawing from it. So if it makes you really hyper and happy and give you a lot of energy, then the withdrawal is likely to be loss of energy, depression, sort of downness. And then the alternative is if it's something that's sort of sedating and calming, the aftermath of it will be a lot of anxiety and sort of restlessness and physical activity. So that makes sense when we think about alcohol. Alcohol is sort of like an anti-anxiety substance. So the withdrawal symptoms involve a lot of anxiety, trembling, irritability, nausea, insomnia, depression, fatigue, loss of appetite. And then again, in severe cases, it can involve hallucinations, confusion, seizures, fever, all kinds of things. So people who are physically dependent on alcohol, people who wake up with the shakes, for example, really need to look into some kind of medical detox process, which is something that we obviously do in a residential setting. So as I said earlier, there are several risk factors for addiction. They're really different for everybody. Some of the most common ones are obviously a family history of addiction, particularly in first-degree relatives. So having a parent who suffers from addiction is a risk factor for addiction. Abuse, neglect, or other traumatic experiences, particularly in childhood. Mental disorders such as depression and anxiety. What I usually say about those to people is that it's a chicken or the egg kind of thing. Are you using because you have depression and anxiety, or are you depressed and anxious because you're using, or is it both? Oftentimes it's both. Early use of drugs or alcohol is actually predictive of addiction later in life. So we often find that people who have started picking up substances in early adolescence to a more intense degree are more likely to suffer from addiction later on in life. And then the method of administration. So smoking or injecting a drug may actually increase its addictive potential. Substance abuse and denial. So the reason I put this on here is that denial is often the biggest barrier that we as treatment providers and as loved ones have to deal with. And denial is sort of like a core feature of addiction because it makes sense if you think about it. The addiction in and of itself wants to keep going because it's helping the person kind of survive and get through whatever's happening in their life. And so if you want to keep doing these things, even though you're having these severe consequences, you're getting DUIs, you're losing your job, you're losing relationships, your mind sort of creates an explanation for that. Oh, well, it wasn't because of this, or it wasn't that bad. And so people who are suffering from addiction often create explanations for why the things around them are falling apart. And those explanations become really firmly set. And when we come in as loved ones to say, hey, you have a problem with drinking, they have an immediate answer because that's exactly what they've been telling themselves for all of these months or years that they've been using. So denial really does the job of resolving that discrepancy between how we're behaving and what we're really intending to do or what our values are. People who have substance abuse problems usually deny them by doing a couple things: drastically underestimating how much they use. So often when people come into a residential program, we'll ask them how much they've been using. And we usually in our minds multiply it by 2, 3, 4, or more than that, because we know that there's so much shame associated with substance use that people often say that they're using less than they are because they're afraid of judgment by others. They'll downplay the negative consequences of their use, which I mentioned, complaining that family or friends are exaggerating the problem, or blaming their use or related problems on others. Do you guys in here have any questions so far? No? Not yet? Okay, great. Let me know if you do. Okay. So these are some myths around substance use that I think are important to address that family members often have in addressing a loved one who suffers from substance abuse. So the first myth often comes from the loved one. I can stop using anytime I want to. So you bring up the conversation. I'm worried about your drinking. I'm worried about your cocaine use. And the person says, it's not a problem. I can stop whenever I want to. The fact is maybe the person can, but more likely they can't. And the way we see it is if they could, they would, right? And it wouldn't be causing the problems that we're seeing. So as we get talking a little bit more about how to intervene with somebody, it's really important to connect the behavior, the substance use, with whatever the consequences are that you're seeing in the person's life. So yeah, they may be able to stop, but it's often important to remind them that they haven't stopped even though they've lost their job, gone to jail, lost the most important relationship in their life, or whatever that thing is. If they could have stopped by then, they would have. The next one is that my substance use is my own problem. I'm the one it hurts and no one else has the right to tell me to stop. The fact is, it's true that the decision to quit using is up to each person, but you're deceiving yourself if you think that your substance use hurts no one else but you. Addiction affects everyone around you, especially the people closest to you. Your problem is their problem. So oftentimes people try to keep it secret, try not to involve their loved ones. But as we all know, loved ones are actually oftentimes more worried about the person than they even are about themselves. So it does affect everybody involved. The next myth is I don't drink every day, or I only drink wine or beer, or I only smoke marijuana, I only smoke at night, so I must not have a problem with it. So alcoholism or any addiction is not defined by what you drink, when you drink it, or even how much you drink. It's the effects of your drinking or substance use that define a problem. So if your drinking is causing problems in your home or work life, you have a drinking problem, whether you drink daily or only on weekends, down shots of tequila or stick to wine. It's not really what you're drinking. Some people even come in, I've had many clients who have binges one weekend a month. And it's not really that big of a problem because it's only one weekend a month. But you come to find out that that one weekend a month, the person's ending up in jail or they're ending up in the hospital, and it keeps happening. That's enough to sort of define a substance use disorder. The next myth is that I'm not an addict because I have a job and I'm doing okay. You don't have to be homeless and drinking out of a brown paper bag to be an addict. Many addicts are able to hold down jobs, get through school, provide for their families. Some are even able to excel. But just because you're a high functioning addict doesn't mean you're not putting yourself or others in danger. Over time, the effects will catch up with you. Next, drinking is not a real addiction like drug abuse. Alcohol is a drug, and alcoholism is every bit as damaging as drug addiction. Alcohol addiction causes changes in the body and brain, and long-term alcohol abuse can have devastating effects on your health, your career, and your relationships. Alcoholics go through physical withdrawal when they stop drinking, just like drug users experience when they quit. The same is true for marijuana use. Myth: overcoming addiction is simply a matter of willpower. You can stop depending on substances if you really want. This is a really tough one for families because it does seem from the outside like people could just stop. And oftentimes people can stop for short periods of time. But the reality is that the brain is changing. When a person is experiencing addiction, their brain is actually being rewired in a way that prioritizes the substance over everything else. So prolonged exposure to addictive substances alters the brain. That results in a way that results in powerful cravings and a compulsion to use. These brain changes make it extremely difficult to quit by sheer force of will. Oftentimes people will say, this time I'm going to try harder. I'm going to work on it. I'm going to do it differently. And the reality is that if it was willpower alone, nobody would be addicted to substances. Willpower alone can't get somebody through it. There's a reality that your brain needs to be rewired, and a lot needs to change in your environment in order to be successful. Using drugs like opioid painkillers are safe since they're so commonly prescribed by doctors. The fact is, short-term medical use of opioid painkillers can help to manage severe pain after an accident or surgery, for example. However, regular or longer-term use of opioids can lead to addiction. Misuse of these drugs or taking someone else's medication can have dangerous, even deadly consequences. Lastly, addiction is a disease. There's nothing that can be done about it. Most experts agree that addiction is a disease that affects the brain, but that doesn't mean anyone is helpless. The brain changes associated with addiction can be treated and reversed through therapy, medication, exercise, and other treatments. Oh, there's a few more. Addicts have to hit rock bottom before they can get better. This is a really common one. Often people suffering from addiction themselves will say, I haven't hit rock bottom yet, so I'm not ready to change. The reality is that recovery can begin at any point, and actually the earlier the better, because oftentimes when people get into recovery and a lot has happened, there's a lot of undoing to do. That also means that they may often be more motivated to make those changes, but just because a person hasn't really lost everything yet, it doesn't mean that they can't start the process of getting better. So don't wait to intervene until the person's lost everything. You can't force someone into treatment, they have to want help. The fact is, treatment doesn't have to be voluntary to be successful. People who are pressured into treatment by their family, employer, or the legal system are just as likely to benefit as those who choose to enter treatment on their own. As they sober up and their thinking clears, many formerly resistant addicts decide they want to change. The research is really mixed on it. Some studies say that forcing people into treatment makes them just as likely to recover as somebody who's going voluntarily. Other studies say it doesn't. My perspective is when people are using, their thinking is so clouded that you have to at least give them the opportunity to have some clear thinking before they decide whether it's the time or not. So intervening with someone and then just not being ready and they're in the midst of using is not necessarily a rule out for getting treatment in this moment. I also think that it may not be the right time for every person in every situation, but getting someone into treatment or at least trying to do treatment is better than the alternative, which is nothing. Last myth is treatment didn't work before, so there's no point in trying again. Recovery from addiction is a long process that often involves setbacks. Relapse doesn't mean that treatment has failed or that sobriety is a lost cause. Rather, it's a signal to get back on track, either by going back to treatment or adjusting the treatment approach. We often at Clearview treat clients who have been to 3, 4, 10, 20 treatment programs. It's not ideal, obviously. It takes a huge financial toll on families, but it's not uncommon that on the 10th time or the 15th time, something clicks, and it's often important to change up the treatment approach. So that's often how people come to us, is that they've tried other approaches and they've heard about DBT, for example, and so they want to try that and see if it works, and we find that it does tend to work for people that other approaches haven't worked for. Addiction in the brain. So as I said earlier, addiction actually alters the brain and changes some of the wiring in the brain. Each substance produces different effects. So for example, something like ecstasy or MDMA impacts primarily your serotonin, but as a byproduct of that, all substances, no matter what it is, alcohol, marijuana, cocaine, heroin, or even compulsive sex, gambling, things like that, they all trigger what's called dopamine, which is like the feel-good drug in the brain. And they alter the way that your brain is functioning. So dopamine is basically telling your brain, this thing is good. I need this thing to survive. And I actually need this thing to survive more than I need anything else. Because if food triggers, let's say, like a 5 on a scale of 0 to 10 of dopamine, methamphetamine or cocaine is going to trigger like 1,000. So food or sex or relationships or exercise, the things that help us release small amounts of dopamine are going to be nothing in comparison to this substance. And so that's why we see people giving up everything, even their own physical health, in order to get the substance, because it feels so much more rewarding than anything else in their life. When you become addicted, the substance takes on the same significance as other survival behaviors, like I said, such as eating or drinking. And that's why we often see people who have a lot of really severe physical manifestations of their addiction, but continue to use because it's really the only thing that is driving their life. The unfortunate part about this is that these changes in the brain actually interfere with your ability to think clearly, exercise good judgment, control your behavior, and feel normal without drugs. The prefrontal cortex, the front part of your brain, is the part of your brain that controls like logic, decision-making, not doing something that's going to be a bad idea, holding off to do something later on because it's better to wait. Those kinds of things, the control parts of our brain, are all in the frontal lobe. And the unfortunate part is that when our brains get addicted, that part of our brain is sort of down-regulating, and the reward centers of the brain, that this feels good, do anything that feels good, gets upregulated. And so that's where we see people intending to do things. I'm going to stop. I won't drink tomorrow. This will be my last drink. And then finding themselves doing it again. It's that part of the control part of the brain is actually not online as much as the get this, do it again part of the brain is. No matter which drug you're addicted to, the uncontrollable cravings to use grow more important than anything else, including family, friends, career, and even your own health and happiness. The urge to use is so strong that your mind finds ways to deny or rationalize the addiction. You may drastically underestimate the quantity of drugs you're taking, how much it impacts your life, and the level of control you have over your drug use. So that's where the denial piece comes in. So these are some signs and symptoms of addiction. Like I said earlier, you usually know if your loved one is addicted to a substance, but people can be secretive, and sometimes we think we know what we're seeing. We ask people about it and they deny it, but there's usually some telltale signs. And each drug has different effects, but the symptoms are all kind of similar. These are some physical warning signs. Again, it depends on the substance, but in general, bloodshot eyes or pupils being larger or smaller than usual, changes in appetite or sleep patterns, sudden weight loss or weight gain, oftentimes like really extreme amounts of weight loss or weight gain, deterioration of physical appearance, personal grooming, unusual smells on breath, body, or clothing, tremors, slurred speech, or impaired coordination. Some of the behavioral warning signs, so the things that we would see overtly, drop in attendance and performance at work or school, unexplained financial problems, borrowing or stealing, engaging in secretive or suspicious behaviors, sudden change in friends, favorite hangouts, and hobbies, frequently getting into trouble like fights, accidents, illegal behaviors. And then some of the psychological warning signs, unexplained changes in personality or attitude. So the person suddenly becomes more secretive, more irritable, used to be friendly and outgoing and is now spending a lot of time in his or her room. Sudden mood swings, irritability or angry outbursts, periods of unusual hyperactivity, agitation, or giddiness, lack of motivation, appearing lethargic or spaced out, and appearing fearful, anxious, or paranoid. So again, each substance is different. So it's not like if the person is using cocaine and another person who's using opioids is going to look exactly the same, but you would see a change in behavior no matter what the substance is. The effects of substance abuse on loved ones. So like I said, there's a lot of physical effects that take place because of substance abuse, but really the social consequences can be just as devastating, if not more so. People who suffer from addiction are more likely to get divorced, have problems with domestic violence, struggle with unemployment, and to live in poverty. So even if an addict is able to succeed at work or hold on to his or her marriage, they often can't escape the effects that it has on their personal relationships. And it often puts an enormous strain on the people closest to you. So that's why we often see loved ones being so motivated to get a person into treatment and make sure that they succeed in treatment. Often family members and close friends feel obligated to cover for the person with the addiction problem, so they take on the burden of cleaning up their messes, lying for them, or working more to make ends meet. Pretending that nothing is wrong and hiding away all of their fears and resentments can take an enormous toll. Children are especially sensitive and can suffer long-lasting emotional trauma when a parent or caretaker is an alcoholic or heavy drinker or substance abuser. One of the things that we'll talk about when we get to how to get somebody into treatment is the ways in which loved ones enable addiction in ways that they don't even realize or definitely don't intend to. It's very rare that you find somebody struggling with addiction who's doing it in a complete vacuum. There's often loved ones that are playing some role in either making things not as bad as they would be or maintaining things in a way that's actually manageable or survivable for the person and is making the addiction continue. So if you suspect that a loved one, a friend, or a family member has an addiction, here's a few things you can do. First, speak up. Talk to the person about your concerns and offer your help and support without being judgmental. Like I said earlier, the earlier you can address the addiction, the better. The problem with this is that oftentimes people keep doing the same thing. Loved ones keep bringing up over and over again that they want to talk to the person about their addiction and the person's not responding. My suggestion is often to speak up when the time is right, but to not keep bringing it up if the person is being resistant. So this is more of like a pointer for families where things are not spoken about or we don't talk about the addiction. Actually bringing it up is a really helpful way to kind of start the conversation. And I often suggest ending the conversation with, I'm gonna leave this alone, but when you're ready to talk about it, just know that I'm here for you. Take care of yourself, stay safe, don't put yourself in dangerous situations, don't get so caught up in someone else's problem that you neglect your own needs. Family members often ask us in the program, what can I do to help my loved one? What would be the most helpful thing I can do? And my answer is always get into your own treatment. Getting your own therapy is the best thing you can do for your loved one, because you will be in a healthier place to help them, and they are less likely to return to their old behaviors because everything will have changed in their environment. Avoid self-blame. You can support a person with a substance abuse problem and encourage treatment, but you can't force an addict to change. You can't control your loved one's decisions. Letting the person accept responsibility for their actions is an essential step along the way to recovery. Don't attempt to punish, threaten, bribe, or preach. This is sort of that like repeated nagging and bothering that we often get into. Don't try to be a martyr. Avoid emotional appeals that may only increase feelings of guilt and the compulsion to use. Don't cover up or make excuses for the addict or shield them from the negative consequences of their behavior. This is a huge one because it's very rare that somebody whose loved ones are thinking about them going into treatment that isn't having really severe consequences in their life. And we often see that loved ones are coming in and actually cleaning up the mess. So like calling into work and saying that they were sick, or the person's engaging in illegal activities in the home and no one's calling the police. And that covering up actually enables the person to continue using because nothing really bad is happening. Don't take over their responsibilities, leaving them with no sense of importance or dignity. Don't hide or throw out their substances. Don't argue with the person when they're intoxicated. Don't use with them, and don't feel guilty or responsible for another person's behavior. Some of this is common sense, like don't use with them, but it's difficult, right? Like as an example, if you as a parent don't have a drinking problem, but you see that your loved one does, and you don't want to make a big deal about it, you go out to dinner and you drink wine with your child because you want them to feel okay, or you don't want it to be a big deal. That's sort of like reinforcing that it's a problem and you're engaging in the behavior with them. Some of the other stuff we find a lot of loved ones will turn into sort of like take on a policing role where they're like taking and throwing away substances. I've had family members bring in drug dogs into the house, drug testing their kids. And some of that's okay once the person has gone through recovery, but when the person is not on board, it sets up a really unhealthy dynamic where the parent is now in the role of not just a loved one, but also like an enforcer, and then often doesn't follow through with the consequences that are set up in place. So why is it so hard to convince someone that they need help? So going back to what we talked about earlier, addiction is a mental disorder that's characterized by patterns of denial and rationalization. There's a couple of things that are important in there. It's a mental disorder. So just like when someone is depressed, they sort of see the world through the lens of things being sad and not working out. When someone is suffering from addiction, it's coloring the way that they see the world. And so what we often say in the program is that addiction speaks to you in your own voice. It's not like people are having their addictive thoughts and they're separate from their own thought process. It is their own thoughts, and so they're believing it as it's coming through. And so they deny and rationalize. So keep in mind that when you're trying to convince someone to get into treatment, addiction is really in the driver's seat. The person that you love, the person whose values you connect with, they're not in the driver's seat. And I usually use the example of the brain, talking about how one part of the brain is sort of offline and another part is kicked into higher gear, to help remind us that we're not really dealing with this person as who they are, but we're dealing with them going through their addiction. So the addiction wants nothing more than to continue to exist, and that's what you're fighting up against. That doesn't mean that the person has lost all rational thought, but it means that they're more motivated to continue in the addiction than they may be to respond to your emotional appeals, for example. So again, this is going back to can and should a person go into treatment against their will? There isn't currently a straightforward way to get somebody into long-term treatment involuntarily unless it's through the court system. But there are ways. So, people can do residential treatment instead of jail time or probation or things like that. The research is mixed on the results of mandatory treatment, but the current thinking is that, again, that any treatment is better than no treatment at all. What I say is that rather than forcing somebody into treatment, you create an environment as a loved one in which the factors that contribute to their ability to maintain their lifestyle is no longer an option, and that their only choice or their best choice is to go into treatment. So as an example, if a person is living in your house and using and not respecting whatever boundaries you've put into place, rather than forcing them into treatment, the wiser approach is to be really firm and specific in your boundaries about whether the person can stay in your home and continue to use, and giving them alternatives such as going to treatment. So either you go to treatment, or you can stay here, but you can't use here. And if you continue to use here, I'm going to ask you to leave. And then following through with those consequences. So one of the things we talk about a lot with family members is that you have to think about what boundaries are reasonable for you, not just in what fits with your value system, but what you're actually going to be willing to follow through with. So parents will say, I'm willing to do anything. And then I present the option of, if the person refuses to go to treatment, are you willing to put them out of your house? Yes. Are you comfortable with them actually sleeping on the streets? No. Right? And that's okay. There's no judgment around that, but we have to be realistic about what we as loved ones are willing to do. Because if you say to the person, you have to leave my house, figure out where you're going to go, and they end up on the street, and then you come in and say, never mind, just kidding, you can come back, that throws the whole thing off, and you've just sort of failed at trying to get the person closer to something. Unfortunately, sometimes it does take going to pretty extreme measures, like having a person leave the house with nowhere to go, or calling the police, for example. Those are like pretty extreme examples of things that family members have to do, but sometimes that's what it takes to get somebody into treatment. When is the best time to have the discussion around going to treatment? Number one, wait until the person is sober. For a couple of reasons. They're more likely to be reasonable. And even if they do commit to something when they're intoxicated, they may not follow through with it once they sober up. I also say, as a rule of thumb, wait at least a day after a significant incident to allow everybody to kind of calm down. Oftentimes people have these discussions in the midst of a huge blow up, and it's just not usually a helpful time to have the discussion. Wait until you have all the information you need before presenting options. So if you're offering for your loved one to go to treatment, but you actually don't know like where they would go, if you have the money to pay for it, what insurance situation is, any of that, it's best to have that information in place so that if they do agree, you can kind of take the next steps. And then wait until you are in an emotional place to accept your loved one's response and follow through with limits. So it's important to think about what will happen if this person doesn't agree. Am I in an emotional place to handle the consequences? Sometimes these things happen when somebody has a 3-week trip to Europe planned. Am I in a place right now to present this and say either you go to treatment or you leave the house? And then if they actually have to leave the house, am I going to be comfortable going on this trip to Europe, knowing that my kid is couch surfing or living on the streets? So finding the time where you feel ready to do it, you've gotten your own support, you're going to Al-Anon meetings, you have your own therapy, whatever that is, to make sure that you're ready for the outcome is also a really important factor to take into account. So what should you focus on during the conversation? Show that you're concerned and that you care. First and foremost, you want to put across that you love the person and care about them. And because addiction is so often characterized by shame, you want to be as compassionate and understanding as you can be, even though there's often a lot of feelings involved. You want to help the person make connections. So you want to think of examples even ahead of time of, hey, this thing happened last week. You never would have done that before, but you did it this time. Or your job used to be so important to you and now you don't show up. Or, you know, your liver numbers were insane last month at the doctor's office. I'm really worried about your health. The doctor's saying this is because of your drinking. Whatever it is, to sort of have the facts in front of you to make the connections for the person. Because again, they're not making, that denial process is making it difficult for them to make those connections. Prepare for the conversation by doing your research beforehand. Try to listen at least as much as you speak, and prepare and communicate your limits clearly. Again, these last two are, I think, really important reasons why loved ones should be in their own therapy. It's really difficult to come up with what your limits are going to be, and you want to know what that is ahead of time. You don't want to just throw it out there. If your limit is that your child or your loved one can stay in the home, but they can't use your car, great. You won't give them any more money. Whatever that is, figuring out what you can do and what you'll be willing to follow through with is super important ahead of time. Things not to talk about. Avoid scary stories. So like making threats by explaining like this horrible thing that happened to somebody else that you know, or what's going to happen to this person is often not something that's going to actually appeal to their motivation. Don't compare your problems to theirs. So oftentimes people will, it's sort of that martyr approach of like, this has been terrible for me, or I've been through things just as hard as you've been through. You should be able to deal with this, sort of like an invalidation. And don't say stuff like you're so selfish or why don't you just stop? Again, invalidating the seriousness or the difficulty in dealing with this problem. Thanks. Okay, the first question is, how come a person shouldn't throw away the drugs or alcohol if they find it in the home? It's a good question. So I think I mentioned it briefly, but this is why we often suggest that clients go into a sober living environment after treatment, is that we want to take the family members out of the role of being an enforcer and like a police officer. We want them to be like a support and a loved one. Throwing away somebody's drugs or alcohol is often going to put you in a position of discord with the person, and it's not likely to stop the behavior anyway. So it sort of just exacerbates the problem. Second question is, what do you recommend someone do in order to sustain their sobriety? I guess in general, is that your question? In general, like I said before, it's an ongoing process, right? So residential treatment is just a piece of the puzzle. Detoxification, residential treatment, and then stabilization. It's an ongoing process of like building support in your life, changing certain lifestyle factors, dealing with the underlying issues, going to meetings, getting a sponsor, right? All kinds of things that are ongoing things that are going to keep you sober, because just going through a 30-day residential program isn't going to be enough to maintain sobriety lifelong. Are there any studies that correlate childhood sugar intake with later in life addiction? Not that I know of. There are definitely studies that correlate ADHD diagnoses, not that that's correlated with sugar intake, but ADHD diagnoses in childhood, and other like conduct disorder diagnoses and oppositional defiant disorder, but not sugar intake as far as I know. Any other questions? Cool. All right. Do I just push mute? Thank you, everybody. Email me if you have any questions.